Okay, welcome to the Good Hormone Health webinar, update on growth hormone and question and answers. We'll spend about 5 minutes on growth hormone, the remainder time on the questions. So people know about growth hormone deficiency. It's what I do a lot of. And in general, I recommend the glucagon stimulation test. It used to be quite readily available in the country, but less and less places are doing it. I think with COVID, people stopped doing it. And there's some places that do it, but less. The growth hormone stimulation test is important because it's needed for growth hormone coverage. It's the gold standard. And the glucagon stimulation test is what I recommend. The insulin tolerance test can be dangerous, discomfortable for patients. The macrolide, it's hard for getting insurance to cover it. It's expensive. It seems to pick up some people that miss people that are growth hormone deficient. You do need to have show that you failed the growth hormone stimulation test in order to get insurance to cover it. We do the test on Sundays at noon and Tuesdays at 5 p.m. My assistant Eric does it. He's done 100 of them, and he's very good at doing it. So I recommend if you're thinking about being growth hormone deficient, you should get the test. You schedule online, contact our office, and we'll make sure that Eric is there that day, as he does tend to go skiing some of the time on Sundays. So once you fail the growth hormone test, and we have a couple hundred patients that are on growth hormone now, it is covered by insurance if you fail it. However, as people know, there are severe growth hormone shortages. We think that some of this has to do with some of the companies that make growth hormone are making Ozempic and Mounjaro, and they're too occupied with that. But there is supply chain shortages. They seem to come and go. And one of the issues seems to be that the patient's preferred insurance can cover one brand of growth hormone, but that's not available. So you have to switch to another brand. You may have to do the appeals if if your insurance covers only one of them. So Judy's been very good at processing growth hormone, and I think people are very patient with Judy. We encourage people to make a $50 PayPal payment to offset Judy's cost, putting the note that is for growth hormone testing. So that would be, if you could do that, that would be helpful. So most people are on growth hormone covered by insurance. There is a cash pay option, either if your insurance doesn't cover it or you don't want to go through your insurance. It's the most common one we use is called Zomactin, and it's about $100 for 5 milligrams. If the dose is 0.4 milligrams, it will last about 12 days, or about $250 a month. If you're on high doses, it can be much more expensive. And this is available either at University Compounding Pharmacy or Ocean Breeze Pharmacy, and these are good sources. There are peptides. There's 2 of them I use. One's called Otropin. It's from a company called Orenda. It's supposed to restore the pituitary. It's delivered by liposomes. It's $48 per month, and it works not as well as growth hormone, but somewhat well. Another one is Cerevital. It's at cerevital.com or Costco. It's $94 for a 40-day supply, so it's a little bit more expensive than the Otropin. Some people like it better. Some people like the Otropin better. There are long-acting growth hormone analogs. There's one. It's called Sogroya, or the generic name is Somapacitan. It's made by Novo Nordisk. It was approved by the FDA for treatment of growth hormone deficiency in 2020, and is made available in the United States for adult growth hormone deficiency in April 2023. It's a long-acting human growth hormone derivative with just small non-covalent albumin-binding moieties attached to facilitate reversible binding to endogenous albumin, delaying its elimination and thereby extending its duration of action with little or no accumulation of the drug when administered once a week. A 26-week phase 3 trial with 92 adults treated with Somapacitan or daily Nortropin. The Somapacitan was well tolerated. IGF-1s basically remained about the same, and generally patients preferred the weekly Somapacitan therapy. And with the shortage of daily growth hormone, Sogroya is an option. Usually the patients that are covered by Nootropic are covered by it, but not necessarily. And some people may not be covered by this, and some people may be covered this. But it is readily available, which is a plus. I usually use the daily dose and convert it times 7 to a weekly dose. The company recommends starting at a low dose. That doesn't make any sense to me, as if you're already on a high dose of growth hormone, you should go on a fairly high dose of this. Sometimes I'll back down a little bit, but in general, it's a conversion of about the daily dose times 7 to the weekly dose. These are the little cartridges here. So let us know if you want to try that. So we're going to move on to the Q&A questions. I cannot give specific advice, medical advice. If you do need specific medical advice, please schedule an appointment, but I can give general advice. So try to ask general questions, and we'll start by asking people in the chat. And you can see the chat here. Chaim says he can't hear anything. Can everybody hear me? Tiffy, can you hear me?
Yes, I can hear you great.
Okay, good. So I think
maybe the volumes were
okay. My volume's on the highest now. Okay. How is growth hormone administered, a pill or a shot? That's a good question. Karen asked. So it is a shot. Because it's a big peptide molecule, it needs to be a shot. It can't be a pill. And the shot is a little needle. The Sogroya is a new one that is once a week, but in general, it's a nightly or daily shot. In general, I usually give it at night. The peptides, the otropin and the cervital, are liquids that go on your tongue, and they don't have to be shots. Melissa asks, is my growth hormone low? I don't know. You need to, we usually monitor growth hormone for people already on it with an IGF-1. The IGF-1 is a screening test, and it's used to see where people are at with their growth hormone. I usually like it in the upper half of the range. But the side effects of growth hormone include swelling, joint pains, especially in your wrist and your hands. So I'll look carefully for that.
Melissa updated a screenshot, and it says it's below 0.1. So
okay, yeah. So we can again look at her.
right.
I don't recommend a random growth hormone. In general, not helpful. In general, I look at the IGF-1. If the IGF-1 is low and you're not on growth hormone, you need to do a stimulation test. If you're already on growth hormone, the random growth hormone is not at all helpful. But you should then let's see what your IGF-1 is. Is Sogroya covered by insurance or not since it's so new? It depends on the insurance. Some of the patients have been able to get good coverage, especially those that are covered by Neutropin. Some of them it's not, and we can do at least one appeal. But if they say it's just not formulary on their formulary, there's not much we can do. Preston asks, is there any added value in taking both growth hormone and the peptide supplements you mentioned? That's a good question, Preston. It depends. Most people I just put on growth hormone. There are a few people that we can't go up on the growth hormone anymore, either because of cost or insurance or side effects. Sometimes I try to add the peptides on top of them, which is an option, but most of the time I usually give one or the other. Kelly asks, is there a quantitative way of knowing who has enough pituitary function to use a supplement that encourages pituitary function? So in general, I would look at the IGF-1. If the IGF-1 is quite low, I would recommend a growth hormone stimulation test. And then if you're low, you go on growth hormone. If your IGF-1 is in the middle of the normal range, near the bottom of the normal range, let's say the range is from 100 to 300. If you're at 120, let's say, I would possibly try the otropin or the supplements and see if it restores your pituitary. If your IGF-1 is like 60 or 80, then I would probably do the growth hormone testing. And another option always is to start the otropin while you're waiting for the stim to do your stim test. You can wait. You should stop the otropin 2 weeks before your stim test, but that would be another option. In general, I also use imaging. So the people that have a small pituitary, they have Sheehan syndrome, they're more likely to be growth hormone deficient. Potentially, the otropin may help them to restore their pituitary. I'm not sure how much it's going to help somebody that really has Sheehan syndrome and a real small pituitary. A lot of my patients have empty cellus syndrome, which is due to a small pituitary, and extra cerebral spinal fluid in replace of the pituitary. So in those patients, I would probably give the growth hormone. I'm not sure the otropin would help. So Melissa's IGF-1 is 153. It's right in the middle of the range. So she's probably not growth hormone deficient. So this is Alice said, should somebody with adult growth hormone deficiency take otropin and the other supplement you mentioned, or choose one or the other? Yeah, I would choose one or the other, either Cerevital or otropin, but not both of them. Amanda says, I have a lump on the back of my neck, and I've gotten 4 different blood panels with elevated thyroid levels twice, and other times they were normal. I got an ultrasound that came back normal. Can't get an endocrine appointment until February. My PCP thinks it might be Cushing's. My cortisol test came back inconclusive. Which let me know what to do next. Any recommendations for next steps? I don't want to wait until February. So you could, I'm happy to see you. You know, I'm booking out not that far, so I might be able to see you before February. You know, I think the issue about Cushing's is certainly possible in a lot of people. I'm not, there's different thyroid tests that could be elevated. The TSH could be elevated, the free T4, free T3. So I think it's definitely worth doing it. The lump on the back of your neck could be a buffalo hump, depends on where it is. They call the neck bump a buffalo hump and so uncomfortable and unsightly. So definitely a buffalo hump can be a very important sign of Cushing's disease. You definitely should be tested for that. You know, I do have people that, you know, have the buffalo hump, and unfortunately their Cushing's test come back normal, and so they don't have Cushing's. It is the blood test, the testing for Cushing's, both the salivary test and the urines that really make the diagnosis. But I would say you should get tested for Cushing's. Can a B12 deficiency contribute to hypopituitary symptoms? I usually don't see that. In general, I try to keep the B12 above 400. But usually the people with B12 deficiency, they may have fatigue or neuropathy, or numbness potentially. But the hypopituitary symptoms are usually quite different. Is there a relationship between partial empty cell and adrenal insufficiency? So that's a good question. That was AKMCD. The pituitary makes several hormones. There's an order of which is most preserved and which is least preserved. The most affected hormone, the first one to be affected is growth hormone, and the last one to be affected is ACTH, which regulates your cortisol. So many people with partial empty cell can have growth hormone deficiency. Some can have central hypothyroidism. Some can have hypogonadism with potentially irregular periods, low testosterone. And then the ACTH is the most preserved, the least one likely to be affected. So those patients with empty cell are the less likely to have adrenal insufficiency, but they could. So it's worth checking all your different pituitary hormones. Heather asked, does growth hormone affect blood sugar levels? And if so, how do you recommend monitoring that? What lifestyle change, if any, should one consider? So in the literature, there's definitely reports that growth hormone raises your hemoglobin A1C, your diabetes markers, and your blood sugars. However, I don't find that to be the case. I find that people on general on growth hormone do much better. They're sleeping better, they're active, they're eating better, they're exercising more, and usually their A1C gets better, not worse. On the other hand, people with untreated growth hormone deficiency, a lot of hypoglycemia with that. So that's one of the reasons why you should be, if you're having frequent hypoglycemia and you have other symptoms consistent with growth hormone deficiency, then I think you'd be a good candidate to be tested for growth hormone and potentially go on it. I always recommend good lifestyle, plenty of exercise, good night's sleep, eating, mostly vegetable diet, cutting down carbs and things like that. Alice asks, if you have confirmed adult growth hormone deficiency or growth hormone with a confirmed pituitary tumor, would you ever let someone just try surgery to remove it, even if they might end up on the other end still having growth hormone deficiency from surgery? That's a great question also. So I've had 2 patients in my thousands of patients with potential growth hormone deficiency that I sent for surgery. They both had very aggressive tumors that was like taking over their pituitary. They were growing rapidly. And so it was because of their aggressive tumors that I sent them for surgery. Their growth hormone, I would say, didn't get better, didn't get worse on that. In general, I would be reluctant to send somebody with just growth hormone deficiency and a pituitary tumor for surgery, because the reason why pituitary tumors cause growth hormone deficiency, and I did publish a paper in Clinical Endocrinology with Kevin Ewan on this about a decade ago, people with pituitary tumors, a lot of them are growth hormone deficient. And we surmise it has to do with the blood flow of the pituitary tumor affecting the blood flow to the rest of the pituitary, so you get growth hormone deficiency. So if you do have surgery, they take out your pituitary tumor, it usually damages your pituitary more than if you didn't have the surgery. So therefore, it usually makes people's growth hormone deficiency worse, and they can also get other hormone deficiencies it rarely makes them get better. Pat asks, can you touch on empty sella? Why, after multiple pituitary surgeries, does it occur? What are the consequences, and can it reverse? So empty sella usually occurs. People could be born with it, but they don't get a pituitary MRI unless they get some kind of imaging, or they come to see me and I suspect growth hormone deficiency. What happens in empty sella is the pituitary is small. It looks flattened on the MRI. It looks like a thin rim. And instead, the pituitary is filled with cerebral spinal fluid. And therefore, the pituitary hormones are deficient. And as I said, growth hormone is the first one to go. Then people can get central hypothyroidism, potentially hypogonadism, testosterone deficiency, potentially even cortisol, ACTH deficiency. All those can occur, but growth hormone is the most common one. And it usually isn't reversed. You treat the symptoms. Now, a lot of my patients with Sheehan syndrome. So Sheehan syndrome happens after delivery. You get sort of a mini stroke in your pituitary, and you get low pituitary hormones. You often get a small pituitary that looks like empty cells as well. Usually people with multiple pituitary surgeries, the pituitary is removed, the remaining pituitary is less and small, and therefore it also could look like an empty cella. I would say there's less of the cerebral spinal fluid present in the people that have had the multiple surgeries. Kelly asks, I have heard and read that we should avoid eating within 2 to 4 hours after doing a growth hormone injection because it can contribute to insulin resistance. What do you recommend for that? That I don't agree with. The growth hormone is, sort of a long-term thing. It doesn't really do that much acutely. It's over a chronic period of time. It builds up in your system, and I don't think you have to avoid eating at all. Alice asks, how common is it to have all three PCOS, the growth hormone deficiency, and Cushing's disease? I would say it's fairly common. So I did write a paper trying to distinguish between PCOS and Cushing's disease. And in general, I found that PCOS has higher testosterone and Cushing's has lower testosterone. And I actually used a cutoff of testosterone of 35 to try to distinguish PCOS from Cushing's, with those above 35 more likely to have PCOS, and those below that likely to have Cushing's. However, both of them can coexist. People with Cushing's gain a lot of weight, and then they're more likely to get insulin resistance, high testosterone levels, and PCOS. So those things can certainly occur together, and there's reports of that also. Now, Cushing's disease can lead to suppression of your growth hormone, so you can also have adult growth hormone deficiency. I don't see much PCOS with growth hormone deficiency itself, but if you have PCOS and Cushing's, you can have growth hormone deficiency. If you have Cushing's, you can have growth hormone deficiency. And usually growth hormone deficiency does not give you Cushing's. However, it does increase the conversion from inactive cortisone to active cortisol in your blood. And it makes you feel a little bit like you have Cushing's. That's why people with growth hormone deficiency may gain weight and have some trouble sleeping. I think that's a component of it, but your blood cells itself aren't affected by growth hormone deficiency. So they are an important triad. Most of my patients, I'm always debating whether and doing tests to try to figure out which one of the three they have, and they should get specific treatments. So therefore, it's important to be tested for all three of them. Should I get tested for anything else other than Cushing's? The buffalo hump becomes next. I think for the buffalo hump itself, the main thing to test for is Cushing's. But if you have other symptoms, you should get tested for whatever those symptoms are, including thyroid problems, growth hormone deficiency, etc. Melissa says, I have partial empty cella, was diagnosed secondary adrenal insufficiency in May 2023 and July 2023. They did an MRI of the pituitary and found partial empty cella, was put on hydrocortisone 20 milligrams, and now have stimmed 3 times, so tapering off now since ended December, down to 5 milligrams of hydrocortisone. So again, that's an example that Melissa probably didn't need the cortisol in the beginning. As I said, cortisol is the first to be preserved. I find the cosentropin test, the cosentropin probably diagnoses too many people with adrenal insufficiency to go on cortisol that may not need it. So it's become a wild goose race. If it's curious if it's more hormonal as a whole panel. Yeah, so I think, you definitely should be tested for growth hormone deficiency. That could manifest a little bit similar to cortisol deficiency. And growth hormone is the first hormone to be affected. The second, you should be tested for central hypothyroidism. Should growth hormone be taken at 9 hours away from food so insulin resistance is increased by it? Again, I don't think there's an insulin resistance issue with it. However, certainly men and children make most of the growth hormone at night, and most women also make most of the growth hormone at night. And your growth hormone is needed, or at least it coincides with when you go into deep sleep. So in general, I give growth hormone at night to try to get so mimic what the body is normally making, and also to mimic your help with your sleep. Most growth hormone deficient patients have trouble sleeping, so it would be a good idea for them to take it at night. Can pituitary tumors cause isolated ACTH deficiency? I would say they could, but that's not that common. Again, in our paper with Kevin Ewan, we had a few patients with isolated ACTH deficiency, but much more of them had growth hormone deficiency. What are your thoughts on the change of the cutoff for adult growth hormone deficiency? So I think you're talking about the cutoff of 1 for obese people. I don't buy that at all. I think 3 should be the cutoff. That's what the Endocrine Society recommends, at least currently. And people with growth hormone deficiency are overweight, sort of by definition. So I don't think you should make it harder for them to go on growth hormone if the growth hormone itself is causing them to be overweight and causing them to be growth hormone deficient. So I use 3 as a cutoff, but occasionally I'll give somebody a value growth hormone if they're between 3 and 5, if they have a small pituitary and have a low IGF-1. Holly asks, do you have a perspective about the use of Ritalin to address chronic fatigue and apathy that come from Cushing's and pituitary issues? Yes, so I did talk about this in my last webinar. Most patients with hypopituitarism, certainly pretty severe hypopituitarism, have what's called pituitary apathy. Here they feel sort of blah, low energy, low mood, apathetic. And these patients respond well to stimulants like Ritalin and don't respond well to antidepressants like SSRIs. I think Ritalin is probably an underutilized medicine because it is a controlled substance, but I find it a very effective medicine. And I think most patients with hypopituitarism should be on it, especially fairly total hypopituitarism. There is some shortages of it, but in general, I find that most people can get a hold of it and can get it. And it can give you more energy, better focus, less apathy, and weight loss, all these things that most of my patients are struggling with. So I think it is a good option for people. I don't use it. I use it more in hypopituitarism than in Cushing's, because in Cushing's, I think you want to treat the underlying problem with either medicines or surgery. Shireen asked, what are the benefits versus side effects of taking estrogen patch and progesterone short and long term? So if you are having regular periods, most people don't need estrogen and progesterone. It's when you stop having periods, either from hypopituitarism or menopause, that you benefit from it. And I do agree with Shireen that estrogen patches are a great choice. I avoid oral estrogens. There was a medicine called Premarin that was quite popular about 20 years ago. That's gone out of favor. We are using estrogen patches or estrogen creams or gels instead of oral estrogen. Progesterone is a good choice, but I don't. I usually give the progesterone. You can either give it continuously at night or cycle it, and I think they're quite effective. I often give people them that are menopausal till 60, but I've had people older than 60 that I've kept on it that are beneficial. The detrimental effects seem to be when you use oral estrogens and when you use it in older people and use people around either early because of hypopituitarism. I think it's quite beneficial to go on estrogen when you're a young person with hypopituitarism and to take the progesterone. Melissa says, I have got a symptomatic tarval cyst in my spine, which is filled with CSF fluid. I think that's a different issue. I don't really know much about that. I would talk to your neurosurgeon. I am said, could low estrogen cause of stress of out adrenals and not necessarily malfunction testes? Most likely not. So in a male, almost all the testosterone is made from the testes, with very little from the adrenals. And in general, your adrenals, make more cortisol and potentially a little testosterone would make them more stressed out, not less. What's the best way to image the pituitary, aka MCDS? Pituitary MRI is by far the best way. I find the quality of the MRIs varies widely. The reading of them varies widely. And some people, my guess is the radiologist doesn't really look at them too carefully. They just put them up and sort of go through them real quickly. I recommend doing a dynamic pituitary MRI. This is watching the dye go into the pituitary and out of the pituitary. I have a checklist that people know about for MRIs, and I found that when people do the checklist, the quality of the MRI is much better. And I can even sort of tell some of the reading. The radiologist might say, we definitely don't see a big pituitary tumor, but I want to see a little pituitary tumor. When they usually say that, I look at the MRI, just not a quality MRI. Either it's blurry, there's not many pituitary focuses. I might say, you need to do a pituitary MRI. It's like taking a picture from across the street if you're doing a brain MRI. It needs to focus on the pituitary, thin cuts through the pituitary, and dynamic is the way to go. Should serum aldosterone after BLA be 0? I would say yes. Does the result of less than 1 mean there's no aldosterone present? Yes, that is correct. So the value is sort of down to 1. So if it's less than that, it usually means it's a complete adrenalectomy, and you'll need aldosterone replacement as well as cortisol replacement. Preston asks, for those who are deficient, can pituitary function recover over time, even partially? Yes. So definitely. So the people with let's say Sheehan syndrome, they have this acute injury when they deliver their baby. That often gets better with time. Patients that have had surgery can often get better with time. Patients, even radiation can sometimes get better with time, but not always. Some people, if they have complete deficiencies, they stay deficient for a while. So you're always reassessing. If the IGF-1 starts going up and you're on the same dose, you put back down a little bit, and eventually have some people that have gotten off of their hormones. Has anyone else reported feeling like NP thyroid is no longer as effective as before? No, I think most people seem to like NP thyroid. It seems to be quite an excellent medicine. There is a new medicine called Athesa, which I think is also very good. ADYTH, Athesa, THYZA. They check each lot individually. It's also very good. Some of my patients like Armour, but I think in general, desiccated thyroids are still quite effective. How do you, Heather asks, how do you know you hit the right dose of growth hormone? What do you look at? I look at the IGF-1. So I like the IGF-1 to be, sort of upper normal range. And I don't want the patient to have the side effects of growth hormone, specifically the hand swelling, the swelling in general, edema. Some people get a pretty severe headache on it. So you try to look at some of the side effects and balance it out for the benefits. Should someone with ADHD switch from Zoloft for depression? Well, I think it depends on how you're doing. If you're doing well on Zoloft, you could probably stay on it. But if you have that pituitary apathy, you might be a good candidate for Ritalin. If you're having poor focus, brain fog, those are all good reasons to potentially switch. Or potentially you can either be on both of them. Chaim says, I have a fat lipoma on the back of my neck. Does this have to do with cortisol or adrenals? No. So the fat lipomas are quite common and unrelated to hormones. Shireen asks, does taking growth hormone cause diabetes in the long term? Again, I would say mostly no. Most people on growth hormone, they feeling better, they're exercising more, they're sleeping better, their energy is better. Their measurements of glucose, such as their A1C, usually improves with time. AKMCT says, is there a relationship between Hashimoto's severe endometriosis, premature ovarian failure, or the menstrual cycle stop, and adrenal insufficiency? So Hashimoto's and premature ovarian failure and adrenal insufficiency are all autoimmune disease. Endometriosis is not, at least we don't think of it as. Endometriosis is not an endocrine problem. It's usually dealt with the gynecological surgery. It's a very common debilitating disease, but it sort of has a different spectrum of symptoms. The Hashimoto's, the premature ovarian failure, and the adrenal insufficiency, at least the adrenal insufficiency of Addison's disease, are all autoimmune, and they may occur quite frequently together. Kelly asked, for those that are pan-hypopituitary and only need Florinef Hydro in the summer, or when inadequately replacing cortisol for a while. It was the reason for that. Aldosterone is partially regulated by the pituitary, but I don't understand exactly how. So that's a good question, Kelly. I agree with you that aldosterone is partially regulated by the pituitary. We think it's mostly regulated by renin from the kidneys, but there is some relationships, and some studies suggest that the pituitary does drive it. So, I would use the symptoms. The symptoms of, you want to distinguish between glucocorticoid insufficiency, where the symptoms are nauseous, vomiting, diarrhea, abdominal pain, joint pains, and aldosterone or mineralocorticoid deficiency, where your symptoms are low blood pressure, tachycardia, rapid heart rate, palpitations, salt craving, dizzy on standing up. So I always like to try to divide the symptoms into those two things. If you have symptoms of aldosterone deficiency, such again as that low blood pressure, dizzy when you stand up, palpitations, rapid heart rate, and your aldosterone is low, you'd be a reasonable candidate to go on fludrocortisone. What ferritin level contributes to chronic fatigue? So I like the ferritin above 70. There was a study in British Medical Journal about 15 years ago that found that the people that had a ferritin level less than 50 benefited from iron in terms of their fatigue improving, while those above 50 didn't. So I think 50 would be a reasonable cutoff. If you're less than that, you should definitely go on iron. It doesn't hurt, and it's definitely a good way to bring up your ferritin level, and you'll feel a lot better when it's up. Iron is a cofactor for your thyroid to work. It's needed for it to bind the receptor and to signal. So getting your iron, your ferritin up is usually beneficial for most people. Is there any natural stuff that replenishes stress adrenals? Also, in Russia and Germany, they have claimed to have peptides, extracts from animal glands. What do you think of these? The Russian one is called Glandocort. I don't recommend these at all. I wouldn't take an adrenal extract. There was one called Isocort that was quite popular by alternative doctors, and then it eventually got switched to like an herbal supplement. But I think it's much better to be, if you are adrenal insufficient, to take that. And in general, these adrenal extracts are for people low cortisol. Chaim, I think we're more concerned with them having higher cortisol. Stress raises your cortisol. It's a fast forward system. So stress usually gives you more cortisol. It doesn't burn out your adrenals. Your adrenals are built to adapt for most people to making more cortisol. Alice asks, if PCOS is in control, testosterone, DHEA, healthy, growth hormones corrected, IGF-1 is in the top third of the range, and the patient has been on Mounjaro for a long time with no weight loss, but ketoconical trials prompted good weight loss. Is that indicative of positive for Cushing's? I would say yes. So, I usually give keto for people with Cushing's. I usually don't give it for people without Cushing's, or in general, I don't. Why would keto be causing weight loss if the patient doesn't have high cortisol labs? So presumably this is me. I usually just start the keto. You must have some positive labs. There might be, some positives mixed in some negatives. But I think keto works in people with Cushing's disease, and I would limit it to people with Cushing's disease, at least some indications of it. I use keto for people that aren't ready to go for surgery, but I have a fairly high suspicion of Cushing's. Heather asks, Sheehan syndrome often leads to weight gain. What do you recommend for weight loss? So firstly, certainly balancing out your hormones is crucial. Being on the proper dose of growth hormone, cortisol, thyroid medicine, etc. I also recommend not giving too much too much cortisol. That's the main thing that can give you weight gain. And then I think your other medicines are reasonable. The GLP-1 receptor agonists. The insurances are getting tougher about coverage of them. So people without diabetes, they probably have to see whether insurance covers Wegovy or Zepbound. Zepbound is the version of Mounjaro you approve for weight loss for people without diabetes. So those are good options. And I use a fair amount of phentermine. Phentermine is much less expensive and works pretty well, although maybe not as well as the GLP-1 receptor agonist. And, if you do have diabetes, then the GLP-1 receptors are more easy to get and usually pretty effective. I always recommend, good lifestyle changes, including diet, exercise, and good sleep and stress reduction. Jamie asks, is type 2 diabetes reversible, or is the damage of having a high A1C at one time irreversible? So yes, it is reversible, and certainly people with better lifestyle changes. There's definitely a lot of reports of people, changing the lifestyle and their A1C improves and the diabetes goes away. However, it depends on how long you've had diabetes and how severe it is. So there's also this concept called beta cell toxicity, where you have high glucose levels that damage your beta cells in your pancreas from making insulin. These people, if you have long-standing diabetes, it's usually not reversible. The cases of reversible are usually fairly new onset or mild diabetes. It can get better with lifestyle changes, certainly in weight loss. So it depends on how long you've had it. It will depend on how reversible it is. Deb asks, what are vestibular symptoms? Why are vestibular symptoms occurring in some Hashimoto's? And have you found certain nutrient deficiencies that are fueling this? I don't think there's a relation. I think for vestibular symptoms, she means sort of vertigo type of issues, I presume. I have not seen that with Hashimoto's particularly, and I don't know of any nutritional deficiencies on that. Karen asks, how long after being cancer-free should one consider growth hormone? That's a good question also. So I think it depends on the cancer. I think if somebody had breast cancer, I probably would not, or colon cancer, I probably would not give them growth hormone at all. If somebody maybe had, carcinoma in ductu in situ, sort of like it's a pre-breast cancer, potentially, a couple of years after being gone, I'd probably like their oncologist to clear them for it. So I think, it depends on what kind of cancer it is, how long afterwards, and sort of clearance with your oncologist. Alice asks, can ketoconazole cause 2-week menstrual cycles, or that more indicative of early menopause? I've seen some abnormal menses with ketoconazole. In general, I always say that extra bleeding is usually due to gynecological problems like polyps or cysts or fibroids, and you should get an ultrasound and see a gynecologist. Missing periods can be due to an endocrine problem, and it could be early menopause. If it is early menopause, you'd see a high FSH, for example. If it is a pituitary problem, you would see probably a low FSH. So I think, getting tested, missing your periods can also be high testosterone. Ketoconazole usually lowers your testosterone, while hysteresis can often raise your testosterone. Barbara asks, for hypopituitarism, for a hypopituitarism patient on growth hormone replacement, would you discourage cervical spinal injections if needed for other reasons such as IIH? Would it affect cortisol levels generally? Yes. So, I think in general, I like to avoid spinal things, but if it's really needed, it's needed. So they should be minimized and kept fairly short. I'm going under lumbar puncture and for a full myelogram to check for intracranial hypertension and CSF leak. I think if you try to minimize the steroid injections if you can, but if you need to, you need to. What causes absorption issues that can result from hypopituitarism? So cortisol is very crucial for your GI tract to work. I think people don't realize that. One of the main issues of cortisol deficiency is like slow GI transit time. You have malabsorption, and therefore in some of my patients, not that many of them, but some of them, I put on either a pump of hydrocortisone or at least subcutaneous hydrocortisone to avoid that whole issue. So it's usually the cortisol that's usually doing it. The hypothyroidism can do it, but most people are sort of adequately treated with their thyroid, so it's not that much of an issue. Should high estrogen be treated? I have central hypogonadism as a male, treating it with 100 milligrams of cypionate injection every week. It's called elevated estrogen. Yes. So this was Chris's question. So I do usually put people on a Arimidex, or it's also called a anastrozole, to lower their estrogen. I think it's quite effective, and you can use a fairly low dose, such as a 0.5 milligram twice a week or so, and that's good. The elevated estrogen can cause gynecomastia or breast tissue enlargement, which you want to avoid. There's one study, at least, that suggested that high estrogen is good for libido. I'm not sure I believe that, but I think in general, I'd like to keep their estrogen sort of a normal range. Alice asks, is somebody with growth hormone deficiency or Cushing's immunocompromised? So I would say no for growth hormone deficiency, especially if you're treated. For Cushing's, you are immunocompromised, especially if it's out of control. And therefore, you're more likely to get, for example, fungal infections, yeast infections potentially. And that's why when I send somebody to surgery, I try to make them eucortisolemic by giving them medicines to normalize their cortisol before the surgery to avoid that. What AKMCD? What effects can Adderall have on the HPA axis? I don't think Adderall has that much effects on it. I haven't seen that looked at carefully, so I think it's probably it doesn't have that much effects. Melissa says an integrated medical medicine doc did a neurotransmitter test and said my neurotransmitters are off the chart. So the neurotransmitters are in your brain. Unless this person did a brain sample, I don't think there's too much relevance to what that person measured, if they're blood or urine test. She was on hydrocortisone for SAI. Could the SAI and the steroid trigger the neurotransmitters or the adrenals burn out from being flight or fright? I just think the test isn't accurate if it's neurotransmitter testing. They suggest amino acids like SAM, SAMe, taurine, and quercetin, and lithium. I would probably not recommend that. I don't think the neurotransmitter testing is that accurate. Kelly asks if someone may be a fast metabolizer of steroids, is there testing that may be beneficial? Is there anything that can help it? Yes. So this is a test that I do that I think I'm the only one who does it basically, but I think it's very valuable. The 17-hydroxysteroids measure cortisol metabolites. When you take hydrocortisone in the morning, let's say you take 20 mg in the morning, a lot of it goes into your urine. It exceeds the ability of the kidneys to reabsorb it. So you'll have a very high UFC if you're taking it. But the 17-hydroxysteroids are the metabolites of cortisol, and they're what's made in the liver throughout the whole day. So that is more integrated throughout the whole day. So I use that 17-hydroxysteroids, and you might as well get the urine free cortisol with it. But the 17-hydroxysteroids are the most valuable test to take if you're on steroids, especially if you're on hydrocortisone. If you're on prednisone, it's not that accurate, I don't think. But for hydrocortisone, it's quite accurate, and that can see how much you're being exposed to per day, and if you're a rapid metabolizer or not. Chris asks, is oxytocin necessary in men? What's the best test for this? So almost all my patients that are on oxytocin are females. But I think you could have it. I take that back. I have some children that had craniopharyngiomas that are on oxytocin. Some of them it helps with their eating control. And there is a 24-hour urine from a company called Running Valley Labs for oxytocin. They're based in Washington State. I don't think the test is fantastic, but I think it's somewhat reliable. So you can get tested for that and see what your symptoms are. And potentially, if your oxytocin level is low, you can go on it. So it may help people with focus and energy, bonding, intimacy. It's called the intimacy hormone or the love hormone. Pat says all the osteoporosis medicines seem more scary than disease. I completely agree with that one. I shared with one of my patients today a webinar by Michael Greger, Greger. I heard him speak at my American College of Lifestyle Medicine conference. All he does is make videos. He just spends his days looking at literature. And he did one on osteoporosis that I listened to actually last night and today, about an hour and a half long video. The medicines are really not good at all for osteoporosis. The main ones, Fosamax or Lendronate, they give what's called atypical fractures. So an atypical fracture means not a fracture by falling off of something or having bad balance and falling. You're just femur, your main bone in your leg just breaks in half. And I don't want that to happen to any of my patients. The medicines seem to be somewhat helpful for preventing lumbar fractured, vertebral fractures. But hip fractures are the main ones that you want to talk about, and they're not that great for that at all, and they have side effects. So what I recommend is, and what he recommended, I recommend going on his website, looking up osteoporosis, Michael Greger, and I recommend exercise and diet basically. So most people have a fracture because they fall. They have bad balance and they fall. And so what you should do is work on your balance, work on your muscle strength. The best thing to do is exercise, much exercise he can. He talked a lot about calcium. The studies have seen, we used to push calcium for everybody. Studies have shown that calcium leads to higher rates of heart disease, heart attacks, strokes. and only helps with your bones a little bit. So I think calcium supplementation is something you shouldn't do at all, basically, is what he said. But how do you get your calcium? Get your calcium from, and milk was found also to be detrimental. More people had more problems, more fractures if they drank milk. So get your calcium from green leafy vegetables is what his conclusion was. I agree with that. The supplement I like the best is called vitamin K2. It's not K vitamin that has to decline, it's K2. 150 micrograms twice a day, I think, is quite a good dose if you're going to take a supplement. He did show some data that vitamin D is helpful. The vitamin D is a little more controversial, but I think your vitamin D is helpful. Try to keep it sort of between 30 and 50. I think that's a reasonable choice. Alice asks, what is the benefit of adding Isturisa to ketoconazole trial? Does the benefit of ketoconazole wear off and Isturisa aids it? Yes. So ketoconazole blocks multiple steps in cortisol synthesis. And therefore I use it first. It has little side effects. It's pretty inexpensive. It's easy to get coverage from it. Most people works quite well because it blocks multiple steps. Isturisa blocks only one step, the 11-beta hydroxysteroid, 11-beta hydroxylase enzyme. And it leads to buildup of cortisol precursors, including testosterone and DHES. So some people get high testosterone, DHES. So I put these androgen precursors that raise your blood pressure. So I put most of the people on Isturisa on spironolactone, or keep them on some ketoconazole plus some Isturisa, because the ketoconazole again blocks most of the steps. Isturisa, which is probably more strong, blocks that one step, but blocks it pretty thoroughly. So there is advantages of adding it. Most people do well on the ketoconazole. I have one patient who's been on ketoconazole for about 14 years or so. She's doing quite well on it. She started seeing me when she was in college. Now she's a lawyer, doing really well as a lawyer. So some of my patients just do really well on it, but some of it does wear off. They get side effects. Their liver tests bump up a little bit, which I don't see that much of happening because I put people on vitamin E and milk thistle to help prevent that. But some people you need to go on to the Isturisa. Melissa says, if getting steroid injections in your back for inflammation causes SAI, secondary adrenal insufficiency, my nurse says yes, and I'll say, my nurse says no, and I'll say yes. So yes, so if you get enough steroid injections, you will suppress your body's own cortisol and your own ACTH and cortisol, and you'll get secondary adrenal insufficiency. If you do one shot a year, you probably won't, but if you do a shot every two or 3 weeks, plus your own nasal steroids and plus your own inhaled steroids, you can definitely suppress your own pituitary adrenal axis. In my county system, we're seeing a rash of these patients that go to Mexico and get these supplements that have steroids in them, and they come back to the United States and they have really low cortisol from that. So definitely you want to avoid these steroid injections, but probably 1 or 2 is okay. Mr. Booth says, if somebody has a goiter and it does not shrink with Synthroid, what can be the cause? So in general, this idea about shrinking goiters with Synthroid was very common about 30 years ago. It's really been shown it doesn't work. So I wouldn't recommend that as a trial. You should go on Synthroid if you have Hashimoto's, if you have hypothyroidism, but not to try to shrink a goiter. Goiters are common. Many of them people just live with. You can go for surgery for it, but most people just sort of live with it. Can too high of iron affect the thyroid? Probably not. Pretty severe iron deficiency may give people somewhat of a goiter. You have these pictures of these people in Africa that have a big goiter. I think some of them were iodine deficient, but some of them possibly are iron deficient. Iron is a cofactor from that. What is the cause if somebody still has a goiter after 12 years? Probably you just have the goiter. You should be tested for Hashimoto's. And if you're on Hashimoto's, you have a TPO antibody, then it might be reasonable to put on thyroid medicine. Heather asks, have you ever seen any allergies with growth hormone use? Yes. I was having itchiness for several years and couldn't place it. Then I tried Segroia, and with a big dose once a week, it became obviously the growth hormone was causing it. Any ideas how to work with it? I'm on Genotropin Mini Quicks now, and it's a little bit better, less preservatives. Yes, I agree. So possibly try different brands. Potentially, you can measure a growth hormone antibodies. I've done that in a couple of patients. So different brands help. The Mini Quicks are preservative free. They may be better. You may be able to try, a lower dose. You may be able to take Benadryl at night to try to overcome it. You may want to try the Otropin or the Cerevital instead is another option. Depends on how bad it is. What would you suspect if somebody has low chronic sodium, polydipsia, and frequent urination? This is for someone who had pituitary surgery. So chronic low sodium could be adrenal insufficiency, and that can give you a polydipsia. Usually diabetes insipidus, where you have polydipsia and frequent urination, you have a high sodium. So I would probably, look at your cortisol levels and do potentially a corticotropin test if needed. You want to maybe measure your urine and serum osmolality after a fast to see if they rise appropriately, to look for diabetes insipidus. But again, diabetes insipidus, you don't usually have a low sodium. Some of the medicines can give you a low sodium. ACE and ARBs can sometimes do it. Diuretics can sometimes do it. So some people just have it. So that's, you have to get worked up more. Alice asks, if 17-hydroxysteroid is high, but other cortisol levels are normal, does that mean you have high cortisol but metabolite fast? So you make sure you have to do the 17-hydroxysteroids per day, not per gram of creatinine. The gram of creatinine is almost always high. There's about, some reports show that there's about 10% of people with Cushing's have a high 17-hydroxy with a normal UFC. And in general, the 17-hydroxy is more integrated throughout the day. Or does that just mean your body is pulling that cortisol out of your fat source and you don't have to have high cortisol? If your 17-hydroxysteroid is consistently high, you have a good chance of having Cushing's. Okay, AKMCD. You mentioned low cortisol and slow digestion when the adrenals are replaced with hydrocortisone. Will digestion improve? They should. But again, you may have to, the dosing is tricky and you may need to do it subcutaneously, for example. I was diagnosed with thyroid-related gastroparesis. In general, gastroparesis is probably not related to your thyroid, but only steroids have helped my gastroparesis and IBS. So you could definitely have cortisol deficiency that could affect your gastroparesis. How long do you have to stop keto before doing cortisol testing? I would wait 2 weeks for testing, stop it before testing. Do you agree with the statement, by definition, anyone on cortisol replacement have at least have times of hyperglycemia? No. So if you're on proper cortisol replacement, and again, if you need to, you can determine this by 17-hydroxysteroids. The dosing should be sort of about 15 milligrams per day. Some people figure it out per kilogram of body weight. You should be a normal person. You should not have hyperglycemia. Do you think this still applies to someone who uses a pump and has a race right? Again, probably not. If you're on proper replacement, I don't think you have having a good chance of having hyperglycemia. My GI is trying to figure out why I'm having some intermittent issues. I think high doses of steroids certainly, they're called glucocorticoids because they raise your cortisol, they raise your glucose. But if you're on proper replacement, you shouldn't have it. My rheumatologist wants me to put it on a biologic for inflammation. Will this affect my cortisol if SAI? I don't think so. So biologics sort of work by different mechanisms. I think they're certainly better than going on prednisone, for example. It suppresses your immune system. I'm a bit apprehensive. It does suppress your immune system. It makes you more likely to infections. But a lot of my patients with rheumatologic problems do quite well on it. Deb asks, is there an endocrine cause for postural or systemic tachycardia syndrome that should be ruled out? Absolutely. So I think POTS is sort of overdiagnosed and it's been taken over by cardiologists when it potentially is an endocrine issue. So I find, first of all, people with low ferritin levels, they frequently have tachycardia. That's worse when they stand up. People with mineralocorticoid deficiency, low blood pressure, have a high pulse, they have it. You should be checked for adrenal insufficiency and mineralocorticoid insufficiency. You should get your aldosterone and renin checked, and potentially you can go on fludrocortisone. Beta blockers, I think people should try to avoid. They wipe out your melatonin system, and a lot of cardiologists put people on that even though they already have low blood pressure. And this medicine Coronar, which actually my son is on, it may help some people. Has a lot of side effects as well.
I think we should move on to some Facebook questions real quick.
Okay, sorry. Yes, let's go do some Facebook questions. Thank you.
Okay, no problem. So Katie asks, about HGH. Are the drops that go under the tongue just as effective? If so, why does everyone take them instead of the shots? And how do you feel about weekly HGH is as effective as the daily dose?
So I'll answer the weekly dose. I think it's effective. It just came on the market fairly recently, so I don't have that much experience, but most patients seem to like it quite well. I mean, it's much more convenient, and there's a the paper showing it works well. And then the shots are not as good as growth hormone. So the Otropin and the Cerevital, I think, are people that are sort of higher IGF-1 or their insurance doesn't cover it. So they're usually not quite as good as the growth hormone itself.
Due to specific dose shortages, my endo prescribed a higher dose, so I went from 0.4 daily to 0.8, 3 to 4 times a week for about a year or more. It's working well with IGF-1 just under 200. Great.
Mm-hmm. Yeah, so I agree with that. With these shortages,
Mhm.
you have to sort of play around with the dosing, whatever you can get. And sometimes, like for example, if I have somebody on 0.6 milligrams and it's hard to get the 0.4 milligrams, I'll have to take the 0.6 milligrams 4 days, 6 days a week or so.
Great. Nicole asks, can you have growth hormone deficiency if early in your illness your IGF-1 is normal or elevated? Have seen recent articles that say you can have GHD even in presence of normal IGF-1 range.
That's a good question also. So in general, less likely. The lower your IGF-1 is, the more likely it is. And there's an overlap though. If the people that have an IGF-1 in the lower half of the range, some of them have growth hormone deficiency. In general, the people with the IGF-1 in the middle of the range or higher, they very rarely have growth hormone deficiency. So the lower it is, the more likely.
Great. Samantha asks, I have panhypo and Hashimoto's. Does HGH impact or change the levels of T4, T3, or TSH?
That's a great question also, Samantha. So people with growth hormone deficiency don't convert T4 to T3 well. T3 is the biologically active hormone. One of the persons who wrote about this, I think he wrote a great article, but he didn't understand the issue. The issue is really not the T4, it's the T3. T3 is the active hormone. He felt that people with growth hormone deficiency have a high free T4. This is Ingrid Johannesson from Sweden. It's really the problem is that they have low T3. And I see that a lot in people that have a growth hormone deficiency and I'm suspicious of it, that they need more T3. So either I put people on the T3 or most likely I treat their growth hormone deficiency and then they convert T4 to T3 well, and they might need less T3.
Great. Tara Lind asks, is there a diet that works with AGHD? I gained 30 pounds last year because I had to go without growth hormone 3 times last year.
Yeah, so again, it's really unfortunate about these shortages, and I think the companies should really try to make sure they have enough growth hormone for people, and insurance companies should make sure they cover whatever brand is available. So if you have growth hormone deficiency, you're out of it, you're not going to do too well. A good chance you're going to gain weight. In general, I recommend again a plant-based, healthy diet, low carbs for everybody, including my growth hormone deficient patients that are off of it. To try to push your exercise, sleep well. All those are good things.
Great. Kim asks, I'm on 0.2 mini quicks for 12 years now. Dr. Gordon tried to raise 2 times a week to 0.4 milligrams. Insurance refused. Anything I can do on my part to help my IGF-1 at 230 range is to 279. Should I push for higher? No pituitary head Cushing's.
So if you're 230 with a range of 279, it's pretty good. I would probably stay there and make sure everything else is optimized. If you're at 130 or something like that, then I would say try to go up. And insurance companies are weasels; they try to get out of payment. So you basically need enough growth hormone to get your IGF-1 to be in that upper normal range.
Great. L.A. Beringer asks, I have Sheen syndrome from 1984. It took 14 years for a diagnosis. I've been on good hormone health treatment for 20 years now at 59. Great job. Abby asks, is it common to have blood sugar regulation issues with growth hormone deficiency?
Yes. So people with growth hormone deficiency, I see a lot of hypoglycemia with it. Growth hormone is a counter-regulatory hormone that helps restore your glucose levels. So if you're growth hormone deficient, you often have low glucose levels. I usually don't see much high, except for the fact that people with growth hormone deficiency feel pretty lousy. They're not sleeping well. They're tired, and therefore they have a tendency to have higher glucose levels.
Mm-hmm. Okay. Does Quest or LabCorp do growth hormone testing?
No, so they do the IGF-1 test, but to do the growth hormone testing, you either have to go to an endocrinologist who does it. And there's not that many of them, as they said in the beginning, or come see us and we'll do the growth hormone testing for you.
Kathy asks, what would explain consistently high levels of ACTH 180 to 230 over the course of a year, but late night salivas and UFCs are all normal? Serum cortisol always low to mid-20s.
Well, serum cortisol in the mid-20s, it seems to be pretty normal or a little bit high. I think either you're not testing your Cushing's when you're in a high, or, one possibility is you could have, really adrenal insufficiency or congenital adrenal hyperplasia also give you a high ACTH that can, that maybe that's why you have high ACTH. If the lab is like missing a lot when they draw your blood, which doesn't sound like if it's drawn on repeated occasions, that can also, raise your ACTH level.
Alina asks, which desiccated thyroid meds do you find work better for Hashimoto's? Thank you.
Okay. Is there any way you can share your screen so people can see the questions?
Oh,
You know about that?
I don't think I can do
sharing.
it this time, but I'll do that next
Okay.
time.
Okay, no problem. I like all the desiccated thyroid medicines. I probably use the most of NP thyroid. These is really good, but it might be a little more expensive. And Armour is good too, but maybe a little less good than NP thyroid.
Mm-hmm. Okay. Amy asks, I wanted to ask your opinion about whether hypopit patients that are confirmed GHD could benefit at all from taking growth hormone producing peptides or GHRH, or if our systems are broken and unable to produce growth hormone even with peptides. I've been on DX growth hormone deficiency and on GH replacement for 10 years.
Yeah, so I think growth hormone is the way to go for people. The peptides, partially either if your pituitary doesn't respond to them, they don't work too well. I just don't think they're that good compared to just taking growth hormone, basically. Trying to give a growth hormone releasing hormone or sermorelin or things like that, they just don't work as well. I think growth hormone is the way to go.
Right. Wondering about reactive hypoglycemia related to growth hormone deficiency or adrenal issues. No diabetes, fasting glucose, and A1C normal by Western medical range. High fasting insulin, CGM showing blood sugar shoot up 140 to 150 and fall rapidly to low 60s and pop back up to upper 90s baseline. Along blood sugar regulation issues, is intermittent fasting beneficial with growth hormone deficiency?
It's a complicated question. So
Yeah.
CGMs, continuous glucose monitors, are extremely valuable tool because they tell you what your glucose is around the clock. Most of what I see, people that don't have diabetes, it affects your, lifestyle modifications. So if you're dropping low, you go up high, then you drop low after eating some carbs. Don't eat those carbs. And then if you're dropping low throughout the night, you might need a bedtime snack, for example. So I think most of what you use the CGM for is really for your diet, unless you have diabetes. In terms of growth hormone deficiency, most people with growth hormone deficiency, they don't get hyperglycemia. It doesn't sound like you're getting hyperglycemia particularly, but I think it sounds like you may just need to watch what your diet is and learn from your CGM what foods you like, you can do, and what foods you can't do.
Okay, we have two more questions. Ellie Beringer asks, so if you test growth hormone AB, would you want a low level, correct?
If you test growth hormone, what?
AB. I don't know what that means. Okay, next. Nicole, if we had a growth hormone antibody tested, we're looking for a low level. What does it mean if it's high?
Right, so high means you have antibodies to growth hormone. Either means that you've been on growth hormone. It's rare, but it means that your body is reacting to the growth hormone. You may need to try a different brand, or you may just need higher growth hormone levels.
Nicole asks, do you have any thoughts on using 10-hour urine sample collections over 24-hour collections for cortisol, one better than the other?
Yeah, so about a decade ago, I used to do the 10-hour collections, but it turns out I had collaborated with people at LabCorp. They had like 20 of the normal volunteers, and they did it also. And the normal volunteers look very similar to Cushing's patients. So I haven't been able to move forward with that. And I think you're sort of stuck with the 24-hour urines. I am, I have talked to Quest people and maybe some LabCorp people about trying to do like a urine test between 10 and 11 at night. But basically, you need to find a lab that's willing to have some normals do that also.
Mm-hmm.
So we stick with the 24-hour urines.
Okay, great. I think we have a couple more questions on Facebook, and then we'll end off. I think we'll start at Alice.
This is on Zoom or Facebook?
Yeah, on Zoom. It was Kelly asked if someone may end up being diagnosed with thyroid eye disease and is panhypopituitary. Is there anything that needs to be brought up with an endocrinologist? I was reading about the antibodies cross-reacting with growth hormone receptors on eye muscles.
I haven't seen much thyroid eye disease related to panhypopituitarism. I think, if anything, maybe there should be less of it. I haven't seen much in terms of growth hormone receptors on eye muscles.
Okay.
Alice asks, are there any pituitary or adrenal conditions that can cause the symptoms of hyperalgesia or pain sensitive sensation than the trigger should have caused? Yeah, that's a good question. I'm not sure about that. Potentially, beta endorphin is on the same precursor as ACTH. So if you are, potentially ACTH deficient, you may have beta endorphin deficiency. So maybe look for ACTH deficiency. And last question would be, Mr. Boo, can somebody with Addison's disease be reversed if someone stays on hydrocortisone long enough? So how common is it? What are the risks for untreated Addison's? Most people with Addison's, it's irreversible. People just have to stay on it the rest of their life. And then the hydrocortisone, if anything, causes your own adrenals to work less. So you're less likely to recover from it, but I think you need to be on it. Untreated Addison's can be fatal. Adrenal cortisol. Cortisol is also life needed hormone, and people with Addison's have both low glucocorticoids and mineralocorticoids, so you do need treatment. People can have heart problems and arrhythmias and pass out and die. And I've had, unfortunately, a couple of patients with adrenal insufficiency that have passed away. Now, Kelly asked, the reason I asked is because my ultrasound showing my eye muscles are too big. We're waiting for an expert to look at the CT scan. Yeah, I'm not sure I have the expertise in that. You can get a thyroid receptor antibody, and growth hormone potentially could improve, expand all your muscles, but I wouldn't think this is that likely. Okay, so let's get to the answers to the question about what will be post. I encourage people to make an appointment with me. That's one of the reasons why I have this webinar, is to get people to come to see me and inform you about. You can see I have a good amount of expertise in many of these areas. The slides and the talk will be on Good Hormone Health. Will also be on YouTube, on Facebook, and will be posted very soon, in probably a day or two. Thank you guys so much. We'll see you later.
Thanks so much, Dr. Friedman. Have a great night.
Thank you so much.
Thank you.